Thank you so much. I think my colleagues in academic oncology will understand, we always have to give disclosures when we stand up here and talk. And I always joke that my disclosure is that I am actually as short as I appear on stage. So I was actually challenged to give a talk to this group about how to live with metastatic breast cancer. And I'm going to do my best to show what I've learned as a clinician, but also as a friend and a son of someone who has themselves been diagnosed with breast cancer. This is me when I was 16. It's amazing at what 2 years can do to you. But this is my friend Christina, who herself was diagnosed with breast cancer in pregnancy. And a lot of this is going to be dedicated to her, and a lot of what I'm going to talk about was informed by my friendship and my relationship with this incredible, incredible woman. So this is not Christina. This is a patient of mine that I saw in a sexual health clinic. So if you want to know what happened, you have to come tomorrow. But she was 60 when I met her, diagnosed initially with stage 4 breast cancer. It was biopsy proven to be in her lungs when she was diagnosed in 2007. She was triple negative, but she had a BRCA2 mutation as well. Primary treatment, because she had metastatic disease, was paclitaxel with bevacizumab. And after 8 weeks of therapy, she had a great response, and so they proceeded with breast surgery. They did a wide excision and actually no dissection. She got whole breast radiation therapy in the context of stage 4 breast cancer, mind you, but she had done so well. They found some residual multifocal disease. All of her nodes were negative. She ended all treatment in November and a month later seized and was found to have brain mets. So this is what she felt. Breast cancer sucks. Metastatic breast cancer sucks even more. There's disability. There's a sense, and I learned this from Christina, of all the things you wanted to do, and there's these roads that weren't traveled in one's life. There's a sense that doors are closing on you before you were ready. Opportunities are lost, future events are going to be missed. Your life becomes medicalized. You live from appointment to appointment to appointment. You plan vacations around chemotherapy. You're afraid to go on vacation because of chemotherapy. And there's a sense of a loss of control. This is normal. This is the normal reaction to breast cancer. It's to mourn what is, what cannot be, and what a future may hold. My advice, though, is not to wallow in that. It's to feel it. It's to own it, embrace it, and then move on. So this is probably the only academic slides I have. Where does breast cancer go? As many of you know already, it likes to go to the bone. But as in my patient, it went to her lungs. It can involve the lining of the lung called the pleura. The liver is involved, and the brain is not that commonly involved. But if you go to autopsy of women who have died from breast cancer, those figures are far more striking. I think the point is, it's probable that women with breast cancer are dealing with a lot more disease than we, as your oncologists, even know about. And I want you to keep that in mind, because we don't need to know everything where that cancer is. We don't need to know all of that, because all these women are living with the disease we can see. Now, where the disease is possibly also being affected, which is why I don't radiate everyone who has liver mets with brain radiation, okay? There's a point to that. Symptoms, as you also know, are based on the site. There's pain and loss of mobility with bone metastases, headaches, confusion, weakness, and seizures if your brain is involved. Your skin can be prone to infections and bleeding. Liver can cause all sorts of things. Lymph nodes can cause loss of function and pain. Metastatic breast cancer is incurable. Metastatic breast cancer is treatable. There is no contraindication, and any breast or general medical oncologist should be saying the same thing to you. This is when I thought about how to advise how to live with metastatic breast cancer. I thought back to how Christina was dealing with it, and I sort of summarized that she came out doing it in a very structured way without even realizing it. And it's what I've termed the PRO approach. And I made up this thing just for this audience. So the PRO approach is pragmatism, realism, and optimism. I'm going to sort of take this through you, and I don't know if it will resonate. But pragmatism is defined as a practical approach to problems and affairs. It's the objective evaluation of the issue and a deliberate assessment of what the next steps should be. It applies to decisions regarding treatment, but also it applies to how you deal with your social networks, your friends and your family. And it deals with how you deal with your community, your church. They're all pragmatic decisions you need to make, in light of dealing with metastatic breast cancer. So what does that mean? Pragmatism means prioritization. What level of inconvenience are you willing to put up with when you're going to talk treatment with your oncologist? What toxicities are acceptable and what are not acceptable? And this might not be something your oncologist agrees with. I write a blog for ASCO, and one of my blogs I wrote about a woman with a recurrent ovarian cancer, and I was, haphazard. I said, well, you need pegylated liposomal doxorubicin, and you've never had it. It's a great drug. You should get it. She was like, no, I'm not taking that drug. I want to wear my heels for however long I'm living. The thought of wearing Birkenstocks is not an option. All right? But that was her threshold. That was where she was like, I draw the line here. Cancer's taken so much from me, it's not taking away my Jimmy Choos. It's just not. All right? So the other thing is, what duration of time are you willing to put up with for treatment? These things should inform how you approach cancer. And you need to factor in everything else, because women and men, our lives don't stop just because you have breast cancer. So you need to think about all those other things, because no one else has to walk in your shoes. So if you take this sort of pragmatic approach to treatment, and you saw this huge list that was presented this morning about all the drugs we can use, and this is just, I think Jennifer and I can probably think of 14 others that we can use. But you can look at it pragmatically about what kind of schedule are you talking about? What are the major toxicities am I going to be exposed to? How long am I going to have to be in the center? How is this thing given? Again, some way to sort of make sense of everything that's being thrown at you, the data, synthesize it all the way down, pragmatically, what do you want to know? Being pragmatic is also important in life. There are only so many things you can do on a day-to-day basis. So you have to prioritize what's important, and it does mean saying no to some things so that you can emphasize the things you want to do. And right now, it's all about you, and it's all about the people you love. So we're going to flip from pragmatism to realism, and realism is a tendency to view things not as they should be, but as they actually are. And when it comes to metastatic breast cancer, cure is not an option, and cancer can be fatal, and that hits you probably on the face, if not every day, at least every month, and that is normal. My advice is always to prepare for an uncertain present and an even more uncertain future. Preparing yourself means sitting down and you taking the prerogative of saying, I'm going to address my advanced care planning, I'm going to name my healthcare proxy. And for Christina, it meant I'm going to pick my casket because I don't want anything, I don't want to live the rest of my life in a bronze box. She was a very natural person. She wanted bamboo. She scoured her city for a bamboo casket, and she found it. It also means preparing your family and friends, engaging them early, not protecting us from what you are going through, because support comes from support, and you have to realize those around you who don't have cancer are probably more sad and scared than we want you to believe. So being realistic also means that no man or woman, is an island. And it means accepting help when it's offered and accepting help when it's needed. And it's acknowledging limitations that are being forced upon you. But that does not mean ceding your independence. And it does not mean ceding who you are. So flipping from that, so how can one be realistic and optimistic at the same time? And I think it is possible. So as an oncologist, the one thing I never leave a patient is I never take away hope. And hope is optimism. It's that hope that treatment will work. And by work, I want you to redefine that even for yourselves. Work, when I prescribe chemotherapy, I always say, it's like, this is not going to cure you. But if we can keep the cancer from growing, I think you can maintain who you are right now. So the goal is stability of that disease. We want to stop it from progressing. We want to do treatments that won't debilitate anybody, because there's always room to adjust schedules and doses. So you get no brownie points by getting the full dose of chemo X every 1 week, as it says on the study. Because even in our clinical trials, there is room to adjust for toxicities. And we have hope that you will live longer, and you'll live long, and you will prosper. So in my way of thinking about this, being optimistic is very realistic for women and men with metastatic breast cancer. Oncology is evolving. We're unraveling the heterogeneity of breast cancer. The sessions this morning sort of showed that. And we're moving towards something that you might have heard, in science and news about precision medical therapy. And I'm I'll stand up from MGH and saying MD Anderson is one of the leaders in trying to promote precision therapy. And it's very likely these gains will be realized while you're here. Precision medicine, by definition, is disease based on the molecular causes and other factors, clinical factors, in addition to the signs and symptoms. It's hopefully going to help us rearrange how we classify cancer, how we classify breast cancer, and inform those diagnoses with big data. How has it been approached? What has the evidence told us? What have the trials said? Summarizing all that to a more precise way of not only defining cancer, but approaching cancer. Breast cancer has led this path already. HER2-positive disease. We now have targeted therapies for HER2. Endocrine therapy being available for hormone receptor-positive breast cancer. And it's probably going to go a step even further. Genomics is showing us that there are triple-negative breast cancers look very much like high-grade serous cancers of the ovary and high-grade cancers of the uterus. So are they actually just one disease type? And can we learn faster if we enroll studies by the genomic classification versus, well, this one started in the breast and this one started in the uterus, so they must be different. BRCA-positive disease, we're still looking for a way to get these PARP inhibitors approved. But the fact is, and the optimism comes from your oncologist, because women with metastatic breast cancer are living longer. You're living so much longer, you have a conference on an annual basis, just for you. And just to cite some of the things that we're working on, you heard about everolimus. It's an mTOR inhibitor. Synergy has been demonstrated with endocrine therapy, and it's synergistic with HER2 therapy. There's a class of drugs called CDK inhibitors, cyclin-dependent kinase inhibitors. It was just given an FDA status of a breakthrough drug, potentially for ER-positive disease. And you heard about PI3 kinase inhibitors and their potential synergy with endocrine therapy. All of these things are in your horizon, and the FDA is trying to help us get these drugs to market quicker. The second column there, that CDK inhibitors are already in a phase 3 trial with letrozole. And that is where I also bring in optimism is a clinical trial. This is something I posted in response to an article where a woman with lung cancer was looking to go into a trial with a vaccine. And the byline was, I don't want to be a guinea pig, but I really want that vaccine. So I tweeted her back, people who participate in clinical trials are not guinea pigs, they're trailblazers, and they're partners as we fight for better. As long as you're realistic, I think clinical trials is a point of optimism for you. Phase 1 trials look at safety and drug metabolism. They're not designed to look at response rates. Phase 2 trials are where we look at response rates, but not necessarily survival. It's a phase 3 trial where we're trying to see if we can change standard of care, and we're looking at those survival endpoints. Hope for better is what drives clinical research on all of these fronts, and we can't do it without a partnership with our patients. So how did my patient do? So she was diagnosed 1 month after presenting with lung metastases, or the brain metastases. She went through about 6 months of therapy with whole brain RT and stereotactic radiosurgery. And then I don't think Dr. Lopez is in the room anymore. For 10 months, she did alternative therapy. So she came back to clinic once a month to check in, but she was doing yoga. She was doing complementary therapies. She was doing everything but chemo, because it didn't really work for her. For 10 months, she was fine. And in December, a study opened at Mass General Hospital. It was a phase 1 trial looking at safety, looking at how the drugs are metabolized, of cisplatin, which was, maybe one of these drugs that are good for triple-negative disease. So cisplatin with a PARP inhibitor called olaparib. She went through 9 cycles of this, and the cisplatin had to stop during because of toxicity. Okay, it caused a neuropathy, which unfortunately isn't reversible. So where is she today? She's stable. Okay. She has not progressed in her brain. She has not progressed in her lungs. She has no disease in her abdomen. And she's thriving. Phase 1 trial, 6 years later, and she's still on that PARP inhibitor. Amazing, but treatment comes at a cost. And living with metastatic breast cancer can create issues, and you deserve to get help for those symptoms. The goal of treatment, when we partner with you to treat metastatic disease, is not to help you live your life. It's to live well. So living not just for the sake of life. So this is where approaching symptoms becomes important as you go through your journey in metastatic breast cancer, no matter what that journey looks like. You've got to approach symptoms proactively. You can do traditional medicines. You can go through psychosocial support, because worry tops one of the biggest symptoms that I hear about. There is complementary as well as alternative care, which you heard about before. But remember, toxicity is individually defined. I can't tell you you're having toxicity, okay? I can't tell you your neuropathy doesn't seem that bad, so we don't have to do anything about it, all right? You have to tell me at what point is this becoming a burden, all right? There's no common threshold to define problem, and symptoms only become problems when you tell me it is becoming a problem. The case in point here is sexual dysfunction. Problems in sexual health are only defined by the amount of distress it causes. And I think the same thing applies to the symptoms you live with. So hot flashes, right, can interfere with function, quality of life, sleep. They can be a side effect of medical therapies, and it can be exacerbated by that alcohol, that Indian food, smoking, and also not being active. Fatigue can be unrelenting, disproportionate, unrelieved, debilitating. Up to 90% have it during treatment, and 40% even after they're off any chemotherapy. Pain. Over 70% of patients have pain, but there are different kinds of pain that you might even say is pain. So that gnawing sense that your feet is asleep is pain, okay? It's different from the pain that you might feel because of that liver met. And it's very different from the pain you might feel because you have pain in your bones. But let us know about it, because we can help. And it doesn't mean throwing opioids at you either, okay? There's a multi-layered way to deal with pain, and we can help you with that. Insomnia affects up to 75%, and there's 2 types, okay? There's difficulty just falling asleep, and there's difficulty staying asleep, all right? In Western medicine, there's something called cognitive behavioral therapy, sort of trying to think about how you're approaching sleep so we can help resolve that. It's a non-pharmacologic way to approach it. There was an herb, valerium, that was looked at for sleep, and it had no effect in a randomized trial. Again, that big cautionary point about complementary therapy. And then there are many other symptoms, shortness of breath, nausea and vomiting, weight loss, and loss of appetite. But distress is probably the one that distresses me the most when I see it. It can be both physical and psychological, but it is very real. And I'm here to tell you that it is real, and if you're having it, you are experiencing this. It's subjective, so I can't order a test until you have significant distress. The treatments can be anything from medications to support, to mind-body interventions, to exercise. Exercise can actually improve distress, as it can fatigue, as it can insomnia. Doris mentioned legacies, and I'm going to sort of end here, because I think when Christina was diagnosed, she started thinking about, how will my children remember me? She had a 2- and a 4-year-old at the time she was diagnosed. We tend to think of legacies as something passed on from an ancestor or predecessor, and we tend to think of these as either money or property or maybe a favorite brooch that your grandmother had that you have now and you want to pass on. But it's not about stuff. Okay? Legacies are what you leave to loved ones, community, and beyond. It's your story. It's your thoughts in a post, a tweet, a blog, a letter. It's your children. It's your friends. And it's the mark you leave on us as your clinicians. I can probably still, it's weird, it's at various points in the year, patients will pop up in my mind that have already succumbed to their breast cancer. I wonder about them. And I would hope that my practice of medicine has been informed by those people that have let me into their lives. So there is a legacy that you leave behind. You don't have to be married. You don't have to have children. But you have a legacy. So it's something that you should try to remember. And if it's important to you, it's another thing that you can work on. But ultimately, I think the way you live will be the legacy you leave behind. This is my friend Dave, who committed suicide earlier this year. It surprised me. I hadn't seen him since college. But when I heard about this, I wrote about it. And this is my example of his legacy to me, and it's that last line. For those he loved and left behind, I hope they know he mattered. The world is a better place because of him. I am certain his influence was shared by more people than just me. Okay? This is a legacy. It has nothing to do with money. Palliative care is something that I'm going to conclude with. It really is it induces such fear and anxiety, but the aim of palliative care is symptom management, and it's not synonymous with hospice. This is a study that was done at the MGH. I don't know if you've had a chance to actually see it, but this is why we're so quick to bring it into the discussion. So this was in lung cancer patients, and the randomization was early palliative care or standard oncology care. This is what they did in palliative care. And look at all of these things. It's what I just talked about in the PRO model. It's about symptom management, decision-making, coping, and referrals. So they took patients with metastatic lung cancer. They were randomly assigned, and they were followed up at 12 weeks. So in terms of moods, the blue line is standard of care. The pink is a palliative care. There were less depression, anxiety with palliative care on board, with standard medical care versus not having palliative care. But patients in palliative care also lived longer. Okay? 12 months versus 9. 3 more months, same medical care, but that extra support made the difference. And with Christina, when she was told she had metastatic disease, her breast cancer doctor brought in that discussion almost secondhand, and she freaked out because she heard hospice. But she and I talked. She went into palliative care, and she had physical support. She had a nurse come in to help her. They were helping her make her kids' meals for her. They were getting her to her appointments. It's all the things we think we want, but I just want you to sort of release the fear that comes with palliative care, because it's so much more than hospice, just like you're so much more than breast cancer. So my conclusions are simple. Get busy living. Be pragmatic. Live realistically. Maintain optimism. Let us help you work for symptoms. Let us help you control them. Let us help you obtain palliative care. Let's aim for a common goal with therapy. we can't promise you complete responses. But if we start talking about disease stability, we're talking about it because it's a good thing. Again, palliative care is important. So you either get busy living or you get busy dying. Okay? So thank you. This is my contact information.
Thank you, Don. Don, I've sub-chaired many meetings, and I've told speakers they've given good talks and excellent talks and sometimes interesting talks. This is the first time I've said this. You've given a beautiful talk. Thank you very much. Thank you.
I appreciate that.
Yeah. Thank you so much. So some questions from the audience. The first question, I spend so much of my time trying to make everyone else feel better about my cancer. It's exhausting. How can I change this about myself?
You've just got to be more selfish. You know? So I guess I can share that with my experience with Chris. Chris lived in London, and when she when I found out she had metastatic disease, it went off in the Facebook setting, and everyone learned within probably 2 weeks. And she was inundated with calls until she just stopped answering our calls. She was like, I want to be with my kids and my husband. I'm going to post on Facebook, though, so you can know how I'm doing. She did it on her terms, and she told us what she needed from us, and that she still loved us, but right now she was just going to do what was right for her. And I don't think any of us felt cheated by that at all. So our responsibilities are to help alleviate stress. If they were causing you more stress, just say, you are stressing me out. All right, and I think most people will back off.
Okay. Next question. Give me a response to give to all the people that say there's always a chance for a miracle.
Well, so how many people think my patient's treatment is a miracle? I see some hands. So, I mean, I think that's what people think about. I think there's so many cultural ways to take that, What do you mean by miracle? You mean that, Lazarus walking from the dead, and you think my doc is Jesus and he's going to do that for me? But I think some people think the miracle is that you'll still be here 10 years from now, 18 years from now. That's going to be the miracle, And people just don't know how to say it, So, it's that sort of, the miracle is that I can walk into a supermarket and people don't know that I have cancer. That's a miracle, because people still have a vision of what cancer looks like, and it's so wrong, so.
Who can best treat my cancer-induced or chemotherapy-induced neuropathy? A neurologist, a pain specialist, or an oncologist?
I would probably say, and I'd be interested in your thoughts on this as well, I would probably say the best people to help manage that are cancer rehabilitation experts. I've been sort of dismayed by referrals of my own patients to general neurologists who put them through all sorts of neurostimulatory tests and a whole MRI of the hand with a neural protocol. And I think, well, it's just Taxol. She's not a diabetic. She didn't have it before. I gave her Taxol, and she has a neuropathy. I mean, So, but I think the cancer rehabilitation field is sensitive to all that, and I think it's more important to find a nice stepwise, systematic approach that makes sense to you. And probably I would say cancer rehab would be the best place to get that.
The next question is dealing with BRCA testing. Is the test for BRCA mutations needed?
So that's a loaded question. Going outside of breast cancer, Memorial Sloan Kettering is testing everyone who walks in with ovarian cancer with a BRCA test because there's a high prevalence. What's curious about this whole field is BRCA mutations, you tend to think you're born with them, right? It's a germline mutation. You go in, family history is positive, I'm going to test it. You realize that your tumor can also have that mutation. even if you didn't. Yeah, I didn't know that either. But there is one of the studies we're looking at in the gynecologic field. They collapsed germline BRCA mutations with tumor BRCA mutations and found far more people could potentially benefit from olaparib. So I guess the question is it needed? I would say yes. I would say it's, I would qualify that to say, what I don't think you should do is go to your primary care doc or gynecologist and just say, can you just give me the blood test? Because that blood test is loaded, and you need to know how to interpret the test, which can be very difficult. And also the other piece of information that sometimes is lost is GINA, which is a Genetic Non-Discrimination Act, Genetic Information Non-Discrimination Act. It prevents health insurance companies from using BRCA status to discriminate against you for health insurance. GINA does not protect against life insurance or long-term care insurance. Okay, so that's something that I also learned recently, but I'm hoping that this community, along with all of us, can advocate to get the law changed. But I think it's so important, and I think therapeutically it could make a big difference.
Okay. Next question. How do doctors decide which tumor to biopsy when there are multiple tumors present?
So I tweeted about this, Jody, about Larry Norton at Memorial Sloan Kettering. I would be curious to see what you thought about it. Had a theory of cancer progression called the self-seeding hypothesis. Have you heard of this? Okay, it's fascinating. So essentially, say you had a breast cancer and there were circulating tumor cells in your body, and you had a known mass in your liver. He wondered why it was only that mass in the liver that tended to grow. Why didn't they develop cancers everywhere? And so the self-seeding hypothesis is that all these cancers stick to areas of known metastases. And it may be even that if you have multiple sites of tumors, the one that makes the most difference is the one that's growing the quickest. Okay? So there are practical aspects on a biopsy. Bone tends to be harder to biopsy than visceral metastases. But if you have 4 or 5 visceral metastases, go for the one that seems to be growing quicker. I have never biopsied 8 or 10 lesions at one time. We usually just go for one site as a representative. And you've heard the caveats of why that may or may not be that accurate. But if I had to choose a site, I always go for the one that's most accessible, that's least dangerous, and perhaps the one that's growing quickest.
Also, potentially the one that's progressed on current therapy, which is another consideration. The next question, what can I take to increase my sexual libido?
Tune in tomorrow.
We didn't plant that commercial.
That's a whole nother hour.
How can I find a cancer rehab specialist?
Yeah, so most cancer centers have rehabilitation specialists that they work with. For folks who are having trouble finding that or in the community and they don't have that, I'm finding there's a lot of parallels for other issues. So women who are having issues with pelvic pain, specialists that do pelvic rehabilitation can generally help you. If you're having neuropathy or neuropathic symptoms or spinal symptoms, there are folks who work with patients who had neurological damage, i.e. from car accidents. And sometimes they can be very helpful. So extrapolating beyond this, I have cancer and I have this issue and I need a cancer rehabilitation specialist. If that's not available to you, try to go by what symptom you are having and help to find, and your doctor can help you find a specialist that maybe can help in that area.
For the last question, I just want to, again, we said this in one of the ER working group sessions. We get a lot of questions about specific therapies, like I've had this treatment and this treatment, what's next? Or we can't answer that on an individual patient basis because that really requires someone to review your chart and to see you and examine you. So I'm going to summarize this question, which is of that nature. But basically, this patient's been started on chemotherapy, and I think the gist of the question is, how do you tell what chemotherapy to start? Is it, do you have clinical trials? Do you look at location of tumor, longevity? How do you know?
You know, that information is actually quite critical to make an individualized choice. I mean, there's numerous ways to treat cancer, numerous ways to treat breast cancer. So a lot of it depends on your goals, what's realistic for you, and what's realistic for us. There are some caveats. Women who have only bone involvement, we probably will not use combination chemotherapy. We probably will not use chemotherapy at all if you're hormone receptor positive. If you're coming in with a liver, lung, multiple lesions, and you have a slight cough, some oncologists may say, you know, we need a response and I'd like to get it quick. So my recommendation is combination chemotherapy. Others may say, you know, yes, you have breast cancer, and it looks like there's a spot in your lung, and I think it's real, but you're feeling so well, and I know Catherine hates that, but you're feeling so well, we could watch it for a while and see what's going to happen, you know. And I can tell you, it's probably there's a 30 to 40% group who hate the idea of chemo in the very beginning, and will look for every reason not to get it because they just don't like poisons. And they'll say, you know what, if you think it's okay just to watch, all right, let's just watch for a while. I'm fine with that. Yep, fine. It's so individual, but yeah, there's some caveats to how we sort of make some decisions. You want to add?